When a patient presents with vague, systemic symptoms like weight loss or mysterious hormonal shifts, pinpointing a pulmonary malignancy requires navigating a complex microscopic landscape. The sheer variety of lung cancers makes diagnosis an immediate challenge. This branching diagram illustrates the first and most critical cut in identifying a lung tumor. Every lung malignancy is sorted into one of two major cellular categories: small cell lung cancer or non-small cell lung cancer. That non-small cell branch further divides into three distinct histological subtypes: adenocarcinoma, large cell carcinoma, and squamous cell carcinoma. Making this initial distinction dictates the entire clinical pathway. Small cell and non-small cell tumors grow at different rates, spread through different mechanisms, and require entirely different chemotherapy and surgical protocols. While viewing a tissue biopsy under a microscope is the definitive way to confirm cell type, the physical location of the tumor inside the lung acts as a reliable anatomical predictor of its cellular identity. To understand how we can predict a tumor's cellular makeup before a biopsy, we must zoom out from the microscopic level and examine the gross anatomy of the respiratory tract. This 3D model of the human tracheobronchial tree highlights three distinct geographic zones where tumors typically develop: the central hilum, the peripheral edges, and the superior apex. A tumor's coordinates within these three zones strongly correlate with the specific histological subtype of the cancer, as well as the exact physical and systemic symptoms a patient will experience. By applying a simple set of phonetic mnemonics, focusing heavily on the letters S and A, we can map these spatial relationships directly to the pathology and lock them into memory. Mastering this spatial map allows clinicians to reverse engineer a tumor's histology straight from a chest X-ray or CT scan, accelerating the diagnostic process. We begin at the core of the respiratory system, the central hilar region, where the main bronchi branch outward from the trachea. Looking at this central zone, a large letter S groups two tumor types: squamous cell and small cell. First, their location. Both are central, spelled with an S, originating near the primary airways. Second, their demographic. Both central cancers are overwhelmingly linked to smoking. It is crucial to note that while they share the S mnemonic and the same central territory, they belong to different histological branches. Squamous is a non-small cell lung cancer, while small cell occupies its own entirely distinct category. Because these tumors grow in the tightly packed central cavity, their expanding mass often compresses nearby major blood vessels, frequently leading to superior vena cava obstruction. A central lung mass discovered in a patient with a smoking history immediately narrows the clinical suspicion down to these two specific S cancers. Separating them requires looking beyond the lungs. Both tumors frequently cause paraneoplastic syndromes, remote systemic effects triggered when the tumor secretes active hormones into the bloodstream. This split-screen logic flow illustrates the different hormonal signatures. On the left, small cell lung cancer frequently triggers SIADH, or syndrome of inappropriate antidiuretic hormone. On the right, squamous cell carcinoma secretes a parathyroid-related peptide, triggering a massive release of calcium from bones into the blood. In a clinical setting, a patient with a squamous cell tumor might present with severe hypercalcemia, experiencing symptoms like confusion and profound weakness. Conversely, a patient with small cell carcinoma secreting excess antidiuretic hormone will retain water, leading to dangerously low sodium levels, causing muscle cramps and nausea. These non-pulmonary, metabolic symptoms are the defining clinical markers used to separate the two S cancers before a biopsy is ever performed. The systemic blood chemistry acts as a remote sensor, revealing the exact cellular makeup of a tumor buried deep in the central airways. Moving away from the main airways, we transition through the narrowing bronchioles to arrive at the expansive, spongy tissue of the alveoli. This distal territory is the primary domain of adenocarcinoma, the most common subtype of non-small cell lung cancer. Looking at the 3D model highlighting the peripheral edges, we apply the A heuristic. Adenocarcinoma is typically located away from the center. This outer placement on the periphery immediately rules out squamous and small cell histologies. While large cell carcinoma is another non-small cell type that can appear in these outer regions, Adenocarcinoma's highly reliable peripheral presentation makes it the definitive anchor for the A mnemonic. When a mass is discovered on the outer margins of a chest scan, the geography almost guarantees an A pathway, dictating a completely different diagnostic approach. Finally, we move our diagnostic focus to the absolute peak of the respiratory structure, the superior apex of the lung. Tumors that develop in this specific anatomical roof are known as Pancoast tumors, or superior sulcus tumors. Pancoast tumors are classified strictly by this apical location, rather than by a specific histology, though in clinical practice they are managed entirely as non-small cell lung cancers. This model reveals the zone's unique mechanical danger. A tumor here compresses the brachial plexus and vertical cervical sympathetic chain. Crushing the brachial plexus causes severe shoulder and arm pain, culminating in hand weakness. Simultaneously, compressing the sympathetic chain disrupts autonomic nerve pathways to the face. A physician will observe the classic clinical triad of Horner syndrome on one side of the face, ptosis, a drooping eyelid, miosis, a constricted pupil, and anhidrosis, a lack of sweating. Unlike the central cancers that secrete hormones, Pancoast tumors bypass metabolic syndromes entirely. Their location creates a purely mechanical footprint of nerve damage. Pulling back to view the entire respiratory tract, we return to the blank map we started with. This completed 3D matrix brings all three geographic zones online simultaneously. We have the central zone for small and squamous cell, the peripheral zone for adenocarcinoma, and the apical zone for Pancoast tumors, each labeled with their associated syndromes. The diagnostic logic forms a reliable grid. A central mass, combined with a history of smoking and hormonal syndromes, points to small or squamous cell. An outer margin mass activates the away heuristic, securely pointing to adenocarcinoma. And an apical mass, combined with mechanical nerve deficits, points directly to a Pancoast tumor. Locking this visual heuristics grid into memory allows students and clinicians to rapidly decode complex board questions or confusing patient presentations. In pulmonary oncology, geography dictates pathology. Mastering this spatial map elegantly bridges the gap between gross anatomy, systemic symptoms, and the microscopic cells driving the disease.